Uh, I'm Ryan Flynn,
And I'm Joya Zaccaro.
and we're doing a presentation on echocardiograms and how they show different kinds of arrhythmia.
The history of the ECG. The very first electrocardiogram was produced in 1887 by Augustus Waller. The Dutch doctor Wilhelm Einthoven, born in 1860, improved the instrument using string wires from a galvanometer, which is an instrument used to measure electric current, and applied this in physiology. The first functional electrocardiograph was produced in 1895, and Wilhelm received the Nobel Prize in Physiology or Medicine in 1924. The electrical activity of the heart. We're going to briefly outline, most of this we already know, but this is going to be an outline. So the source of electrical activity is a network of specialized cardiac muscle fibers. The autorhythmic fibers are the pacemaker cells. And also we have the cardiac conduction cells, both of which make up about 1% of the cardiac muscle fibers. Their function is to repeatedly generate action potentials that trigger heart contractions, which in turn causes the cardiac chambers to become stimulated to contract in a coordinated manner, which makes the heart an effective pump. So these two types of cells, the pacemaker cells, excitation begins in the SA node. And as mentioned, pacemaker potential repeatedly depolarizes two thresholds spontaneously. Each action potential from the SA node propagates throughout both atria, through to the atria to contract at the same time. The cardiac conduction system continues along atrial muscle fibers where the action potential reaches the AV node or bundle. Here, the action potential slows to provide time for the atria to empty their blood into the ventricles. From the AV node, the action potential enters the AV bundle and propagates along the left and right branches to the apex of the heart. Purkinje fibers rapidly conduct the action potential upward to the remainder of the ventricular myocardium. So the basic principles of the EKG. The EKG passes the signal from each lead through a buffer and amplifies the signal to a readable level. The output voltage is a result of the formula V naught equals G V positive minus V negative, where V positive and V negative are the polar leads, G is the amplifier, and V naught is the final signal. From tissues to wave, the electrocardiograph. Electrical currents generated in the heart muscle tissue are transmitted to the skin, where they are detected and recorded by an electrocardiograph, which produces an electrocardiogram. Because electrically charged particles move, they generate an electrical vector that together produces waves. And you can see the fibers in this picture and their correlation to what we're going to be talking about. So we have a horizontal axis, which includes duration and time intervals, vertical axis, which involves direction, either being positive or negative, and an amplitude, which is the height to which the positive or negative would reach. And then kind of a combination of both involves the shape, and it could be smooth or rounded or even pointed.
Okay, so capturing heart physiology, the electrode types and the placement. Electrodes placed on the skin are exploring and reference electrodes. As you can see here, here's a reference electrode, here's a exploring electrode. Positive or exploring electrodes are vectors heading toward the exploring vector yields positive wave. Negative reference electrodes, vector heading away from the exploring yields a negative wave. The exploring electrode lies anteriorly on the chest wall. Reference electrodes are on the limb of electrodes, or they are the electrodes on the limb. So your right arm, left leg, right leg. So the lead types are either bipolar or unipolar. Bipolars are two electrodes of opposite polarity, so there will be two heads of that electrode, and then it will pass a current between them to complete the wave. It measures across those 2 points. A unipolar electrode is a single positive electrode and a reference point to measure the electric impulses at only 1 point. Lead groups, there are 3 bipolar limb leads, 1, 2, and 3. There are 3 unipolar limb leads, AVR, AVL, and AVF. There are 6 unipolar chest leads. They're also called precordial leads, and they are denoted by a V beforehand, and it's just 1 through 6. Leads relative to the heart on the right side are V1 and AVR. On the left side, you have V5, V6, 1, and AVL. AV standing for atrioventricular. Between the right and left sides are V2, V3, and V4. On the inferior aspect is leads 2, 3, and AVF. Gioia, do you want to take this one or?
Sure.
Okay.
The 3 bipolar limb leads, 1, 2, and 3. As mentioned, these are 2 electrodes of opposite polarity. So lead 1, we have the right arm is negative, the left arm is positive. Lead 2, the right arm is negative, the left leg is positive. Lead 3, the left arm is negative, the left leg is positive. And you can see the picture of the diagram of the points that are, like, imagine a human body that would be laying under this. 3 unipolar limb leads, AVR, AVL, AVF, as mentioned before. These have a single positive lead with a reference point. So AVR is positive electrode from the right shoulder, AVL positive from the left, and AVF positive on the foot. And the 6 unipolar chest leads, the number 1 is the 4th intercostal space, and you can look at the diagram below it. To the sternum's right, number 2 is the 4th intercostal space to the sternum's left. Number 3 is midway between V2 and 4. V4 is around the 5th intercostal space at the mid-clavicular line. V5 is anterior axillary line leveled with V4. And V6 is at the axillary line leveled with V4 and 5.
So here are just some images for how all those leads end up displaying information on an ECG or EKG, depending on where you're originating from. So lead 1 will line up here and it'll sort of follow along. And here's a diagram just sort of showing you where each lead places an image of the heart from that perspective. There's also another way it can be sort of shown where it'll always just have a denotation, just sort of telling you where it's taking that perspective from. As far as the actual output of an ECG, each of these small squares, these 1 by 1 millimeter blocks, represent a 40 millisecond time period and vertically a 0.1 millivolt amplitude. A 5 by 5 box will represent 0.2 seconds or 200 milliseconds time and half a millivolt amplitude. So here would be an example of 1 millivolt, and it'd be 10 millimeters high as a reference pulse. So the P wave is, in normal circumstances, the depolarization of the right and left atria. It's a normal wave when the electrical impulse is originated in the SA node and normal depolarization of the right first part of the wave and left atria second part of the wave. It is found by lead 2. The direction is positive, moving upward on an ECG. The duration is 1/10 of a second. The amplitude would be anywhere from 0.5 to 2.5 millimeters or millivolts, I believe. The shape is smooth and round, and the interval will usually last anywhere from 0.12 to 0.2 seconds from P to R. The QRS complex is that spike that you see on an ECG, and that is the depolarization of the right and left ventricles. The normal wave is an electrical impulse from a bundle of the Purkinje fibers through the right and left bundle branches with normal depolarization of the right and left ventricles. The direction for Q is negative, moving downward. Then the R is that spike that you see moving extremely high on the positive direction. And S is when it goes right back down to baseline levels. The interval lasts about 0.8 seconds or 0.08 seconds, or on the higher end, 0.1 seconds. The T wave is the repolarization of ventricles during the last part of the ventricular systole. The normal wave begins at the surface of the ventricles, progresses in through ventricle walls. The direction is positive. The duration is 0.1 seconds to 0.25 seconds. The amplitude is typically a bit over 5 millimeters or 5 millivolts. The shape is sharply or bluntly round, and it's usually a bit asymmetrical. So it will sort of be leaning to one side more than another. So one of the first deficiencies that you can see in an ECG pertaining to someone's health is an electrolyte deficiency. And there's a couple different electrolytes that includes. There's a calcium deficiency, a potassium deficiency, and a sodium deficiency. A sodium deficiency will not show up in an ECG, but a potassium deficiency, also known as hypokalemia, is where the T wave is wider, the lower amplitude or inversion, or has a lower amplitude or inversion. The P wave amplitude and duration increase, as you can sort of see here. The calcium or hypocalcemia deficiency is a shorter QRS duration or a longer Q to T interval. With excess electrolytes, you're going to see a shorter QT interval with hypercalcemia, a longer QRS duration, or bradycardia. With hyperkalemia, at a mild level, it'll be a pointed T wave. Moderate hyperkalemia will involve even more pointed T waves. The P waves will be wider. P wave amplitude will decrease. PR interval will be prolonged, and the ST segment will be elevated. At the severe level, everything is going to become even more pronounced. The QRS period will be wider, as you can see here with examples of increasing severity. And with sodium hypernatremia, there'll be, again, no effect on the ECG. Okay, so here are some of the examples of what actually causes the heart to enter arrhythmia. So there's going to be abnormal automaticity, where the SA node, for example, could be dysfunctional and latent pacemakers. It could be the AV node, possibly. It could be surrounding Purkinje fibers, and any other of the latent pacemakers of the heart are now going to be competing unintentionally over the heart's rhythm. Conditions like hypoxia or myocardial ischemia can cause the latent pacemakers of the heart to interfere by bringing the resting heart rate membrane potential closer to depolarization. That'll increase the frequency of pumps, and these events are called triggered activity. When an impulse meets cells that aren't excitable, re-entry occurs and causes the impulse to loop and cause atrial flutter, among other possibilities. So here are some examples of atrioventricular node disorders. The Mobitz type 1 AVE blocks are a progressive increase of the P to R interval until an impulse is skipped over and the baseline rhythm restarts the sequence. The second type of the Mobitz block are impulses without progressive change, but every second or third beat passes through. The first degree atrioventricular block have a PR interval greater than 0.2 seconds. These are often asymptomatic, although at increased risk, and can be found in highly trained athletes. Third degree heart blocks are an entire failure to conduct impulses to the ventricles. QRS signals are very narrow. Sinoatrium blocks are usually not found at all inside a normal EKG. You'd have to get an internal ECG or EKG to detect. And here's an example of how it sort of divides up those signals. You can see where this SA node sort of goes off, the right atrium, and see how it sort of lines up to a normal surface ECG. These blocks are, okay, so first degree SA blocks. These blocks are a longer period between the SA node firing an impulse and atrial depolarization. The delay is constant and can appear totally normal on surface ECGs. Because you can see, here's a normal ECG. The P wave is at a constant pace, but here you can see that the actual sinoatrial signal is preceding the P wave by a good millisecond. So the second degree type 1 blocks are called Weichenbach blocks. Type 1 involves a PR interval that gradually increases, and the P to P interval shortens until an impulse is blocked, as you can see here. The pause interval resulting from the block is twice the length of the preceding cardiac interval. The second degree type 2 is a more sporadic sort of interruption without the progressive overload indication seen in Weichenbach patterns. Anywhere from 1 to 3 impulses are entirely blocked. Certain arrhythmias can present as bradycardia, as you can see right here. They'll still be constantly spaced out, but you will actually it'd be right here, where they're constantly spaced out evenly, but you can see that they're missing actual beats. The third degree blocks have no impulses from the SA node. Latent pacemakers assume control, establishing escape rhythm, which is why mortality is low even if the node entirely fails. And for the last slide, ventricular tachycardia. This is an example here of a monomorphic form. It can be caused by various heart diseases, primarily coronary artery disease, heart failure, cardiomyopathy, or valvular heart disease. It can emerge from re-entry, high automaticity, or triggered activity. More than 3 ventricular beats between 100 and 250 beats per minute is the basic requirement for anything that would fall under this. 100 to 120 is actually called a slow ventricular tachycardia, and above 250 beats per minute is considered ventricular flutter. And one of the main effects of this is atrioventricular dissociation, where the atrium and ventricles are beating independently, and you can actually see that there's a few different examples of how the P waves are slightly different from the last. And I do believe that is the end of our presentation.